Good afternoon, everybody. Welcome back. Sorry, for our second day of event. اليوم طبعا احنا في عندنا 4 محاضرات. We have 4 lectures for today. Dr. Usman, he presented his lecture yesterday. صار عندنا 3 والدكتور Dr. Paula from Italy, he asked to replace his lecture to be done on 25th or 26th due to commitments. Is Dr. Nicola around? Dr. Nicola? Dr. Sonal Sikar?
I am here. Yeah.
Dr. Sonal, how are you?
I am good.
Okay, do you mind that we can start with you because I cannot hear Dr. Nicola? Maybe he's late or
yeah, no problem. I can start my presentation.
Okay, 1 minute, Dr. Sonal. Thank you very much for joining us.
Yeah, thank you.
Dr. Sonal, he's our friend. He's an assistant professor, Department of Pharmacy Practice, Manipal College of Pharmaceutical Sciences, Manipal Academy of Higher Education from India. Dr. Sonal received his pharma PhD and MD degree from Rajiv Gandhi University of Health Sciences, Bangalore, India, and the PhD from the Manipal Academy of Higher Education. Thank you very much, Doctor, for joining us, and please proceed. Thank you very much.
Yeah. You make me host?
Yes, دكتور سعد بالله يحول الهوست للدكتور لو سمحت.
Yeah, I can do. Yeah.
Okay.
My slide is visible?
Yes, it's obvious. Yes, go ahead.
Okay, good. I think now it is good evening for everyone. So my name is Dr. Sonal Shekhar. Already LRB has given the opportunity. I am very thankful for the Dr. LRB for giving this opportunity, for sharing my experience on diabetic foot ulcer during this diabetes symposium. So the topic I am going to talk today is actually diabetic foot ulcer research, a personal experience. Before going to the topic, I want to start my presentation with a quote by T.D. Jakes. The world is a university and everyone in it is a teacher. Make sure when you wake up in the morning, you go to the school. For coming half an hour, I want to discuss following topic with you. So overview of diabetes and foot ulcer and pharmacoepidemiological research in diabetic foot ulcer. Then some of the quality of life studies, what we have performed on diabetic foot ulcer, then educational intervention and its importance in the management of diabetic foot ulcer, and some nutritional research and some of the alternative hypotheses what we have put forward for further research, and even the challenges of diabetic foot ulcer, especially during this COVID period, and conclusion. So yesterday's speakers already talked about a lot about the diabetes and its problem. So I want to reinstate the same during my presentation also. According to International Diabetic Federation, their 9th edition of Diabetic Atlas, they have mentioned that around 5.7 million are living with diabetes in the worldwide. If you see, among that, around 1 in 10 people, so half of these people does not know they have the diabetes. That means they are underdiagnosed. That means they does not know they have the diabetes. So if you see, 3 in 4 people with diabetes were living in the low and middle income country. So the care of the diabetes also, these populations are not getting proper way. That's most of these are people are living in the resource poor settings. If you see the global prevalence of diabetes, you can see that North America and Caribbean islands, there is around 51 million people have diabetes. South and even the Central America, they have 32 million people, and Europe is around 61 million people. So Middle East and North Africa have 73 million. Rest of Africa have 24 million, and Southeast Asia, including India, we have around 30 million people have the diabetes, and West Pacific countries have 306 million diabetes people. So you can see, all of us know that the metabolic abnormalities of diabetes may stimulate the overproduction of mitochondrial superoxides in the endothelial cells in the small and large vessels. So thereby it will generate oxidative stress. Okay, these have the potential, this oxidative stress have potential role in the development of complication of diabetes. So you can see that diabetes foot ulcer is one of the most debilitating complications of the diabetes. Moreover, you can see it is a severe public health problem issue. But still, you can see that there is very less studies have reported global epidemiology of diabetic foot ulcer. So if you see the epidemiology of diabetic foot ulcer, what are the available studies or evidence what it is reported? Okay, diabetic foot ulcer affects between 15 to 25% of people with diabetes during their lifetime. So if you see the prevalence of diabetes in hospitalized patients, it is ranging from 4 to 10%. So recently, that 2019, there was a systemic review and meta-analysis that have reported that the global prevalence of diabetes, where diabetic foot ulcer is around 6.3%. So among that, North America have the highest prevalence of the diabetic foot ulcer. It's highly surprising that this is a very developed country. So the highest prevalence of the diabetic foot ulcer is in the North America, that is 13%. Then you can see that Africa has 7.2%. Asia have 5.5% of diabetic foot ulcer, and Europe have 5.1%. Most less low level of prevalence you can see in Oceania countries. So if you see the epidemiology, like you can see the male have more prevalence of the diabetic foot ulcer compared to female. Apart from that, the people who have type 2 diabetes have the more prevalence of the diabetic foot ulcers compared to diabetic type 1 diabetes patients. Apart from that, diabetic foot ulcers patients, most of them have older people. Then they have low BMI, then longer diabetic duration, and had more hypertension and diabetes compared to those who without diabetic foot ulcer. Moreover, you can see, if you see the recurrence rate of the diabetic foot ulcer also, that is also very high. So one study estimated the pooled recurrence rate for the diabetic foot ulcer, that is showing that around 22.1% a year. So recurrence rate is actually varying, and even it is region to region, it is different. The trend is actually the recurrence rate is compared to earlier, few decades before. Now you can see that there is a decrease in the recurrence rate in terms of diabetic foot ulcer. So apart from that, you can see this a 5-year mortality rate in the diabetic patients after the foot ulceration is a 40%. It's very high mortality rate. Okay, amputation in the diabetic patients is around 10 to 20 times more compared to non-diabetic patients. Moreover, you can see that according to International Diabetic Federation data, every 30 seconds, a lower limb, part of the lower limb is lost worldwide due to the diabetes mellitus. So you can see that current therapy does not have conclusive and consistent evidence on the efficacy as well as the cost effectiveness in the diabetic foot ulcer management. Moreover, you can see that usually it's very challenged to treat the diabetic foot ulcer. Usually today or yesterday also you have seen various surgeons have shared their experience. Okay, so all of you know that very well. You are already involving for that management part. It is very slow to heal and difficult to manage, and even it could exist for several weeks or sometimes several months to get healed. So all this was a severe challenge to treat the diabetic foot ulcer. The clinical settings alone, we had to, this should be a continuous care, even though patient is discharged and went to the home also, there should be a continuous care. We had to extend the care at the home setting also. So therefore, we required an alternative strategy with minimal adverse effects for the better management of diabetic foot ulcer. It is a need of time now for the new strategies and new techniques to manage the diabetic foot ulcer. So in this introduction, I want to share my experience on diabetic foot ulcer. Some of the one study what we have done on the diabetic foot ulcer, it is actually antimicrobial susceptibility pattern in the of aerobes in the diabetic foot ulcer. So we have done the studies, almost 3 years we have done. So we have included a cross-section study. We have recruited around 260 diabetic foot ulcer patients. Those who are admitted in our Kasturba hospital, that is a tertiary care hospital. So what we had done, these patients' culture specimens were observed as a gram stain smear and cultured aerobically on the blood agar and Bacon-Key agar plates. And antimicrobial susceptibility test we have performed by this diffusion technique according to and laboratory standard institution guidelines. Our result shows that there is a total of 354 microbes were isolated from the patients of 213 diabetic foot ulcer patients ulcer. That shows that average 1.7 organisms we have isolated from each lesions of diabetic foot ulcer. Majority of this foot ulcer is infected with polymicrobial agents. Moreover, we have seen that gram-negative organisms are more compared to gram-positive. However, we have seen if you go to the individual the organisms, the most common one is actually gram-positive one, methicillin sensitive. Among the gram-positive, methicillin sensitive, Staphylococcus aureus, that is the most common. After that, Enterococcus bacteria, Streptococcus, and Staphylococcus resistant. These are the gram-positive one. Gram-negative organism, what we have seen is actually Pseudomonas, and after that, Proteus mirabilis, Proteus vulgaris, Klebsiella pneumonia, and you can see Klebsiella oxycoca and Acinetobacter. So these are the gram-negative organisms we have seen in our patients. So findings of that studies, what we have seen, based upon antimicrobial susceptibility pattern, we have developed an antibiogram. Okay, the antibiogram is cumulative antimicrobial susceptibility pattern we have developed. So what we have seen is doxycycline would be the appropriate in our settings. This is applicable to our setting. So doxycycline would be the appropriate choice as a single drug for empirical coverage for gram-positive organism. But the most appropriate antibiotic for the gram-negative organism, meropenem, then one of the critical observation what we have seen, the multi-drug resistant strain of Acinetobacter. So this is a study about the antimicrobial susceptibility. Then we have done a studies on the quality of life on the diabetic foot ulcer patient. One of the study what we have done is actually impact of diabetic foot on the quality of life compared to diabetes patients. So that means we try to determine what impact diabetic foot alone have on the quality of life compared to diabetes patients. For that, we have recruited, this is actually a cross-section study. We have two groups here. One is actually a study group. That means diabetic foot ulcer patient. A control group contain only diabetic patient. So we have recruited here 200 diabetic foot ulcer patient and 200 diabetic patients. To assess the quality of life, we have used the standard questionnaire that is called RAN36. So that is used to evaluate the health and quality of life. That will be given for both group, study group as well as control group. So apart from that, study group is actually used one more questionnaire, that is diabetic food ulcer short form questionnaire also, that contains some 39 questions. So findings of that study in both control group as well as study group of the poor health related quality of life for all the subscale. There are 8 subscale in the RAND 36. All these subscales have the very poor in both group, study control group as well as study group. But what we have seen is still, even though it is poor in both groups, there's a significant difference in the statistically. If you see between the group, that means study group that have the diabetic foot ulcer have a highly compromised or very poor quality of life compared to diabetes patient, even though both have the poor quality of life. Apart from that, summary score for the health related quality of life also we have seen. That means there are 2 summary score, that is called physical component summary score and mental components summary score. Both group is actually very poor physical as well as mental component summary score. However, there is a statistically significant difference between both group. That means the study group have highly compromised physical as well as mental component summary score. After that, we have focused on educational intervention. For that purpose, we have developed a patient information leaflet. Okay, this is one of our study published in the International Journal for Endocrinology as well as Metabolism. So for that, we have developed a patient information leaflet to provide the patient education for the diabetic foot ulcer. So this patient educational material is how developed by referring to various standard resources, including Patient UK. So you can see that this developed patient information leaflet is actually assessed for its readability by using the fresh reading is method. After that, fresh reading is method, we have done user testing in the small set of patient, diabetic foot ulcer patient, recruited 34 diabetic foot ulcer patient. Using the COSI experimental study design, we have evaluated the patient information leaflet. Additionally, we have used the user opinion for the legibility as well as content of patient information leaflet. Apart from that, the design as well as the design characteristics of pill was assessed by using the Baker-able leaflet design method, BALD method also we have employed. So this is the leaflet what we have developed. You can see that there are a lot of points, self-care for the diabetic foot ulcer. So some of the points I will just read out. You should avoid walking barefoot. You may have to ask to wear special shoes or insoles to relieve the pressure on your feet. Like that, you can see the patient educational forms, points we have put in this patient information leaflet. So another study what we had done by using this questionnaire, validated questionnaire, validated patient information leaflet, we have done educational intervention study. So this educational intervention study, what we have done is to see the impact of patient education on the quality of life of diabetic foot ulcer patient. Okay, for the education, so the patient information leaflet what we have developed, so that we have used. So for that study, we have recruited around 135 diabetic foot ulcer patient. Okay, so they have divided into 2 groups. 65 subjects were in control group and 70 subjects were included in the education intervention group. After that, we have the RAND 36 questionnaire, assess their quality of life. So the result you can see here, the baseline health-related quality of life in the intervention group as well as control group was very poor. But after 6 months of educational intervention, you can see that remarkable improvement in the health-related quality of life in the intervention group compared to control group as well as baseline of intervention. Okay, compared to that, after 6 months, there's a remarkable improvement in all the subscales as well as summary scales of this questionnaire. So what I want to conclude from this particular study is a remarkable improvement in the health-related quality of life, the intervention group after the 6-month follow-up that suggests that this patient education have the significant role in the improvement of quality of life of diabetic foot ulcer patients. So after that, there are a lot of another study what we have done. It is under review in the food journal. It's not so far published. So there are a lot of reports, evidences on the conflicting evidence, I can say, on the impact of food metformin therapy on wound healing. Some of the literature is favoring the metformin used in the wound healing. Some of the studies are actually saying that metformin may delay the wound healing in the diabetic foot ulcer patients. To find the answer for that, we have done a small pilot study by recruiting around 76 diabetic foot ulcer patients. It was a prospective cohort study we have performed by recruiting 44 diabetic foot ulcer patients in the study group. Study group is actually the diabetic foot ulcer patient. Those are receiving the metformin. Whereas reference group are actually the patient who are on the other anti-diabetic drug other than the metformin, like maybe insulin or oral hypoglycemic agent other than metformin. So in that reference cohort, we have 32 patients, and study cohort, we have 44 patients with a mean age group of 58. So the mean healing time for study cohort, what we observe is 2 months, and whereas the median healing time for the reference group is 1 month. So this table shows the association between metformin use and wound healing. That shows that there is a statistically significant difference was found in the wound healing between study cohort as well as reference cohort. So that indicates that there is an increased wound healing time in the metformin group compared to other patients on other anti-diabetic medications, including insulin. So this table shows the association between metformin use as well as incidence of amputation. So what we can observe here, in the study group, around 70% of the patients underwent the amputation, whereas only 30% does not underwent among the study group. Whereas reference group, you can see that only 46%, that means roughly 47% have underwent amputation. 53 didn't underwent amputation. So there's a significant difference was found in the incidence of amputation between the study group and reference group. Okay, that indicates there is a higher incidence of amputation among the patients who are on the metformin therapy. So you can see that earlier, what are the current treatment, there are a lot of challenges for the current therapy. For example, you can see most of the diabetic foot ulcer, it will finally end up with the foot infection. Then we have to start the antibiotic therapy we have. So the most of these antibiotic therapies are actually complicated, and even it leads to the adverse effect, as well as it can cause to the antimicrobial resistance. So therefore, we need some alternative approaches, or we have to encourage the alternative therapy like nutrition therapy and new method to tackle these issues. So among the, we have, to considering that thing, we have proposed one hypothesis. It is published in the Medical Hypothesis Journal. It's actually topical applications or formulation of probiotic for the management of diabetic foot ulcer. So far, there is no topical application for the probiotic formulations for the treating the diabetic foot ulcer. So we have proposed this hypothesis based upon the concept that probiotic modulate our local and systemic immunity. So what we have proposed here, mechanism of this anti-infective and ulcer healing action of this probiotic is similar in the peripheral wound as well as ulcer, as like any other part of the body. Because other part of the body like GI and even you can see oral, okay, probiotic already it has shown the effectiveness for healing the infections and even the healing the ulcers, okay, gastric ulcers and even the oral ulcers. They are already probiotic has shown its effectiveness for treating that. So we are assuming that the same effect can be shown in the peripheral wound also. Based upon this hypothesis, we have derived a mechanism. You can see that antibiotic can modulate systemic as well as surface immunity. How it will modulate systemic and surface immunity? You can see that stimulate the peripheral wound cells to secrete anti-inflammatory cytokines. Apart from that, probiotic will release various anti-inflammatory mediators and peptides. Okay, so that will kill or inhibit the various pathogen. Apart from that, this probiotic will competitively inhibit for the addition site with pathogen. However, probiotic like lactobacillus, it will reduce the acidic pH, will use acidic media. So that acidic media will inhibit the growth of or survival of the pathogen. So thereby it will improve our local immunity. Apart from that, systemic immunity it will improve by it will activate the macrophages and dendritic cells. And macrophages, you can see, and dendritic cells, it will release various cytokines that will stimulate the release of various T cells, okay, so especially T helper cells like 1 to 17 and T regulatory cell also. Thereby, it will modulate our skin functions to acting on the skin axis. Thereby, it will decrease the susceptibility of the skin to the various infections. So this is what the hypothesis we have proposed for the topical application of probiotic for the wound healing and even the diabetic foot infection also. So finally, currently we are working on the effect of diabetic foot, the effect of vitamin D supplementation in the diabetic foot ulcer. So why we have came up with this idea, you can see that the vitamin D have a significant role in the cell proliferation as well as differentiation and even the modulation. So what it can do is that vitamin D can stimulate the T cells as well as B cells, whereby it will result in the suppression of immunoglobulin auto. So you can see that there are a lot of evidences are coming up now. You can see clinical and clinical shows that vitamin D influences the multiple phases of wound healing, and thereby it will accelerate the wound healing process. Okay. Apart from that, it will stimulate various cells involved for the proliferation and even the remodeling phases in the wound healing. So additionally, you can see that vitamin D enhances the expression of antimicrobial, especially cathecillin. That helps in to eliminate microbes as well as it will suppress the pro-inflammatory responses while enhancing the anti-inflammatory responses. All these evidence shows that vitamin D supplementation can be improve the or it can given as an adjuvant therapy with standard care for the diabetic foot ulcer treatment. So finally, to conclude my presentation, like you can see that we are seeing the incidence of diabetes. That is actually exponentially the incidence of diabetes is increasing worldwide. So along with that, we can see that diabetic foot ulcer incidence also will increase. Therefore, there's a preventive strategy. The research should mainly focus on the preventive strategy for the diabetic foot ulcer in the near future. Moreover, the recurrence also you have seen. So we need urgent attention for the recurrence, to prevent the recurrence of diabetic foot ulcer. Additionally, the novel approaches such as topical probiotic therapy, we have to test and we have to try. So it will be beneficial for the treating diabetic complications such as diabetic foot ulcer. So currently we can see that there's a great challenges for the not only in the treatment sector of diabetic foot ulcer, even in the research also because of this COVID. One of the problem what we are seeing now, diabetic foot ulcer patients load is came down in the hospital. That is not because of the patients are not there. That is because of patient is reluctant to the visit to the hospital because they are afraid that they will get the COVID infection. So the studies, whatever already we have started, there's a drastic decline in the recruitment process because of the low level of low number of the patient. Apart from that, another problem what we are facing is actually wherever the follow-up is required, we are not able to follow the patient. So now what we are trying, some of the what we can telehealth approaches we are trying, wherever the possible, we are through the remote, we are trying to access the patient through the remote access, or even one effective strategic method what we are developing now, all these questionnaires, what are the, for example, quality of life questionnaires that we are planning to develop in the Android platform, and that questionnaires will be installed in the patient mobile. So the patient itself, the first visit itself, we will install that questionnaire in the patient mobile. So whenever instead of coming to hospital after the follow-up period time, patient itself can fill that questionnaire and send us back. So that's one of the strategy we are following. Some of our studies, survey studies, presently. So all these points, to conclude my study, is a presentation here. So I want to end my presentation by another quote by you: learn, no one can help you, but if you are determined to learn, no one can stop you. So thank you very much.
Thank you very much, Dr. Sonal. It's really a nice, overwhelming, really lecture, and you have touched a lot of important things. One of them, do you think that meropenem, you mentioned that meropenem is the best drug, but do you think utilizing meropenem, especially in gram-negative bacteria, would be the first line of therapy? As you know, we are suffering quite frequently from the resistant bacteria. So what do you think about this issue?
Yeah, ectropion, you can use the ectropion have both gram-positive and gram-negative organism. It is beneficial, ectropion. So what the normal standard dose what we can give for ectropion is actually 1 gram per day. That is actually the standard dose what we can give for the ectropion. So even doxycycline also have coverage for gram-positive as well as gram-negative. So usually what we can give somewhere like loading dose of doxycycline somewhere around 200 mg you can give. The subsequently maintenance dose around 100 mg you can give doxycycline.
But you know, doxycycline in many centers, it's not considered one of the first line options. Usually doxycycline is kept as a standby in case of either resistant bacteria are on the horizon.
Okay.
So any explanation why is doxycycline is in your list of antibiotics?
Yeah, so in the problem here in India, we even though we have the different guidelines, but the infection control measures actually little not stringent rules are not implemented. So even doxycycline also we are using as a first line drug in our settings actually. So this is settings to settings, it will differ. I can understand what from your concern, but in India you can see that most of these antibiotic, even the over the counter also it is available. So that is the situation in India. So in your situations it will be totally different, but in our situation doxycycline doctors are suffering because it has the benefit behind that. Maybe it has beneficial for anaerobes also actually. Some of the diabetic foot ulcer, you can see that the anaerobes also you can see. So it has the doxycycline can cover all these three kinds, gram-positive, gram-negative, as well as it has beneficial effect on the anaerobes also. The problem here in maybe the resource poor setting is actually the reason behind using that. Why? Because in your settings, maybe a close monitoring of the patient will be there. But Indian settings, that patient, most of these patients are from the rural settings. then again that getting the patients and assess the patient very closely, it will be difficult. Once they came and taken the treatment, following it will be very difficult. To considering that, the doctor sometimes the higher end antibiotic also they will give as a initial line of therapy here.
Thank you very much. In your article about topical application of probiotics, what exactly did you use to enhance the treatment or the healing of the foot ulcer? How did you get it?
Can you repeat the question?
In your article about topical application of probiotics, what you have done in short to enhance wound healing of diabetic foot? Because, you know, it is a complex issue.
Yes, sir. Yeah, as you mentioned, exactly, this is actually hypothesis what we have put forward. So this is actually clinically, it is not tested. So this is actually, we have to start from the preclinical study onwards. This is just an hypothesis we have given by giving the justification of what may be the possible beneficial effect of this probiotic. So because probiotic, we can see that it is using for other. Hello.
Yes, go ahead.
Yeah. So far it is not topically it is used. There is no formulation so far. It is not available. But somebody can do this study and develop a formulation in the topically and preclinical analysis. If you done and if it is proven, then we can try in the clinical settings. Still, it is working. We can use in a routine medical practice.
And the antimicrobial susceptibility pattern that you discuss in your article. So you suggest that meropenem and doxycycline are one of your best options to handle bacterial infection and diabetic foot?
Yeah, that actually that depends upon the infection. As you mentioned, if it is a gram negative, gram positive, even clindamycin is effective, gram positive cases. Or if it is not a severe infection, some mild infection, even the amoxicillin clavulanic acid also combinations also effective. But if some cases you can see most of the time it will be polymicrobial, multiple organisms, or even the ESBL extended spectrum. Okay, that cases we have to go for meropenem or higher end antibiotic we have to give. Piperacillin tazobactam also we can try if there is actually polymicrobial agents are present.
Actually, it is interesting to know that. I think Dr. Abdullah Al-Wahbi, our co-organizer. Dr. Abdullah, any question?
Yeah, can you hear me?
Yes, go ahead, Dr. Abdullah.
Yeah, thank you, Dr. Sonal, for a very nice presentation. I just have one comment about antibiotics. As you mentioned, and Dr. Harbi mentioned about meropenem and doxycycline. As you know, we are having a big problem with bacteria with multiple resistant to antibiotic, and we consider meropenem and doxycycline are the last line to counteract these organisms. So what we do is actually in any diabetic foot that you have to make sure you debrided the tissue and take good culture and try to use the antibiotics, which are the first lines at first as much as you can. And even when we do that, we frequently seeing now patients who comes in with organisms which are resistant to almost all antibiotics. So I think if we mention that meropenem and doxycycline are used at the first line, that will increase the resistance. So that's one point. The other point is a question about your point about metformin. Could you explain? You said that metformin has decreased the incidence or increased the healing chance of ulcers, but however, it increased the amputation rate. So first question is can you explain that? And the second question, why you think metformin has this effect on diabetic foot ulcers other than compared to insulin and other drugs? Thank you.
So your second question, can you repeat, sir?
The metformin issue, you mentioned that metformin, when you did a study, that patients on metformin, ulcers healed better than the control group. That, if I understood that.
No, sorry, that is opposite, other way around. The metformin group, there is a delay wound healing.
And amputation, increased amputation rate.
Yeah, even it is increasing the amputation also.
So why do you think that? What do you think the mechanism?
Yeah, it is actually inhibiting the proliferation of the cells. The metformin, there is a chance to increase. It is an AMPK activator, so thereby it will increase the. Actually, it will decrease the the proliferation of the cells. So
okay.
thereby it is actually delaying the wound healing.
So that means your recommendation is that the endocrinologist or they should use other medication and keep away from metformin?
Yeah. So actually, this is actually a preliminary study with a very small sample size. But what I'm recommending here, we need a well-controlled study using the both group, actually, metformin and other group. So this is just our preliminary. That's what during the presentation also I have mentioned. This is a small sample we have used. So it cannot be generalized, or we can final conclusion we cannot make from this actually. But our observation, we have seen that the metformin group have more wound healing delay, as well as incidence of amputation also more among this group. But from that, we cannot conclude, as you mentioned.
Exactly. Excellent. Excellent. I think it needs further investigation on that. Thank you so much. Thank you so much.
Thank you. Thank you.
Dr. Sonal, we have two questions from the chat box.
Okay.
The first question is saying that why do you think that metformin has adversely affect wound healing, and how do you explain this? I think you answered this partially with Dr. Abdullah.
Yeah.
And the second question is it for all diabetic patients or only for patients with diabetic foot?
What was? Okay.
He's asking about the metformin effect. Is it for all diabetic
patients or only for the patients? Only all diabetic patients mean, I didn't get you. Metformin is a first-line choice of drug for diabetic management.
So he's saying, what is your recommendation as a replacement?
Yeah, that's what I mentioned, that actually we can conclude. It's not giving a thorough evidence that we are not supposed to use the metformin. So we should see in a large trial we had to do, and we had to see that still it is actually showing the delay. But otherwise, all diabetic patients should receive the metformin. That's what actually IDA, American Diabetic Association, all the guidelines are recommending. Diabetes patients, we had to try the metformin first, type 2 diabetes.
I see. Any question from the audience, please? أي سؤال يا أخوان؟ Welcome. Thank you very much, Dr. Sonal. It is a great pleasure joining us. It is very important.
Thank you very much. Yeah, it's my honor to attend. Thank you. Thank you.
Very informative. Thank you very much.
Thank you.
Dr. Tirozi around, is he? Dr. Tirozi? Dr. Nicola Tirozi. Unmute yourself, please, Dr. Nicola.
Good evening.
Oh, Dr. Tirozi, how's Italy?
Yeah, it's sunny, even in Italy.
Thank you very much for joining us, Dr. Nicola. He's a consultant vascular surgeon and endovascular surgery at the Department of Vascular and Endovascular San Giovanni di Dodo Hospital, Florence in Italy. And Dr. Nicola is he's a consultant in vascular and endovascular surgery since 2013 at the Department of Surgery and Vascular Endovascular Surgery Unit of San Giovanni Dio Hospital, Florence, Italy. And in 2017, Dr. Tirosi achieved the University Master in Healthcare Management at the University of Florence. Thank you very much, Doctor. Please proceed for your presentation.
Yes, I share my screen. I really thank you for the kind invitation. It's a privilege for me to be here. And to be honest, in the last months, I changed my job position because I moved from the public hospital in Florence, as you mentioned before, and I moved to University of Pisa, another city in Tuscany, Italy, close to Florence, and I am now assistant professor of vascular surgery at University of Pisa. I remain the surgeon, and I am a clinical professor of vascular surgery at the University of Pisa. And the topic of my lecture is quite different from the lecture we had before. And I would like to share with you some studies I performed about the pedal arch and the importance of pedal arch in diabetic patients. Okay. We know that some years ago, in particular in the beginning of 20th years, the theory of angiosome has begun. Everyone knows this kind of theory, the importance of angiosome theory, in particular in terms of reconstruction, incisions, and revascularization of the foot. The theory of angiosomes supports the idea that every skin territory has been supplied by a particular artery, medial plantar artery, lateral plantar artery, or anterior tibial artery, etc., etc. But we know that the angiosome theory does not have strength, does not have strong evidence in literature. And so in this systematic review published in 2017 in European Journal of Vascular and Endovascular Surgery, these authors concluded that direct revascularization of the tibial vessels appears to result in improved wound healing and limb salvage rates. However, the quality of evidence is still low. Therefore, in the same time, there was a great interest not only in the angiosome theory, but also in the foot vessel anatomy, above all in terms of radiographic anatomy of the foot, because in the past, I am quite young, but when I began with vascular surgery in the middle of 1990s years, a lot of old vascular surgeons said to me that the vascular surgery ends at the knees, okay? So no vascularization of tibial vessels or the foot vessels, but during the years, we improved our knowledge about the anatomy, the radiographic anatomy and the vascular anatomy of the foot arteries. And therefore, we know that there is there are a lot of vessels into the foot, and there is the pedal arch. It's very important because the pedal arch connects the pedis artery to the plantar and medial artery, starting from the posterior tibial artery, and a lot of vessels, and in particular the interdigital vessels born from the pedal arch, just to irrorate the fingers of the foot. Okay, so we know that oh, I'm sorry, but my videos do not run, because I would like to show you that this kind of disease is very different from other diseases, because we have the femoropopliteal disease, we have the BTK, so the below the knee disease, but we have also the BTA disease, such as the below the ankle disease. We can have some patients with perfect tibial vessels and occlusion of the foot arteries. Okay, I'm sorry for the videos, but I would like to share with you this paper because when I read this paper in 2013, I remained very impressed about this paper, published from some vascular surgeons in London. And Isham Rashid demonstrated that in patients with CLI, the outcomes of an intrapopliteal surgical bypass could be affected by the patency of the pedal arch. And significant differences have been found in healing and time to healing between the complete, incomplete, and absent pedal arch of the foot. And so the authors concluded that the rates for healing and time to healing were directly influenced by the quality of the pedal arch rather than the angiosome revascularized. So I had the inspiration to perform some personal studies about the angiosome theory and the pedal arch, and I would like to share with you my personal studies. The first studies is an analysis of clinical outcomes after peripheral revascularization on the basis of the pedal arch status, and the second study is an analysis of clinical outcomes after BTK revascularization on the basis of pedal arch rather than angiosome revascularization. Okay, the aim of the first study was to evaluate the impact of pedal arch quality on the tissue loss and time to healing in diabetic patients with CLTI undergoing endovascular revascularization. So substantially, I duplicated the paper published in JVS by the colleagues of London about surgical bypass, and I repeated the paper in the endovascular treatment of the BTK vessels in patients, in diabetic patients with the CLTI. So I enrolled in my personal clinical experience about 150 diabetic patients with CLTI underwent endovascular peripheral revascularization, and according to the final angiography of the foot, I divided the patients in 3 groups according to the final status of pedal arch. Complete pedal arch, as you can see in this slide on the left side, incomplete pedal arch, so no connection between the pedis artery and the plantar or lateral lateral or plantar medial artery, and or absent pedal arch, so absence of pedis artery and absence of plantar arteries. All the data of the procedures have been collected in a dedicated database, and I performed a simple statistical analysis in terms of a Kaplan-Meier curves with the aim to demonstrate the one-year outcomes in terms of freedom from minor amputation, limb salvage, and survival. Okay, and as you can see in this slide, this is the distribution of the 3 groups in terms of the pedal arch status. Complete pedal arch in about 1/3 of the cases, incomplete pedal arch in about 45% of the cases, and absent pedal arch in about 1/4 of the cases. And you can see in this slide that the patency of the pedal arch affects the wound healing rate. And you can see that the wound healing rate is better in patients with complete pedal arch, about 78% of the cases. And in patients with absent pedal arch, the wound healing rate is 1/3, about 32%. And if we analyze the time to healing, so the wound healing is faster in patients with complete pedal arch rather than patients with absent or incomplete pedal arch, with a P significant difference 0.003. Okay, but very surprising, according to me, in my opinion, it's the one-year limb salvage, because the patency of the pedal arch affects the limb salvage of our patient at 1 year. You can see in this slide the Kaplan-Meier curve with 100% of limb salvage in patient with complete pedal arch, about 95% of limb salvage in patient with incomplete pedal arch, and about 70% of limb salvage in patient with absent pedal arch. And very surprising very surprisingly for me, even the survival of these patients has been affected by the patency of the pedal arch. And you can see that in this slide that the 1 year survival of this patient at 1 year is about 60% in patients with absent pedal arch and about 93% in patients with complete pedal arch. Okay, and I published this first study in 2018 in Korean Journal of Radiology, and the title is very explicative with the impact of pedal arch patency on tissue loss and time to healing in diabetic patients, okay? Okay, and let's go on. I would like to share with you my second study about pedal arch, and this second study is a comparative study between the direct or non-direct angiosome revascularization rather than the pedal arch status. But in this second study, I would make a focus on BTK revascularization. So I enrolled in this second study just 93 diabetic patients with foot wounds undergoing endovascular revascularization of BTK vessels, and the correlation between the location of the wound and the revascularized BTK vessels was used to classify the procedures in direct angiosome revascularization and non-direct angiosome revascularization. And even in this case, the final angiography was used to divide the patients in 3 groups according to the pedal arch status. And I performed the same statistical analysis, but in this second study, as you can see in the next slide, I performed a comparative studies between angiosome, non-angiosome revascularization and the pedal arch status. So a direct angiosome revascularization has been obtained in about 60% of the cases, and you can see that the patency of the pedal arch is complete in about 1/4 of the cases, incomplete in 43% of the cases, and absent in about 31% of the cases. And when we analyze the outcomes in terms of angiosome revascularization or indirect angiosome revascularization, we can see that there is no statistically significant differences in terms of wound healing within 3 months. So the angiosome direct revascularization did not affect our wound healing. But if we analyze the outcomes in terms of pedal arch again, the pedal arch affected the wound healing within 3 months with 45% of wound healing within 3 months in patients with complete pedal arch, and about 15–20% of wound healing within 3 months in patients with incomplete or absent pedal arch. And if we analyze the outcomes at 1 year, the limb salvage has not been affected by the direct or non-direct angiosome revascularization. On the other hand, even in this case, in patients with BTK lesions, diabetic patients with BTK lesions, the 1 year limb salvage has been affected by the pedal arch status, with a 100% gain of limb salvage in patients with complete pedal arch. And if we analyze the outcomes in terms of survival, the angiosome or non-angiosome direct revascularization did not affect the 1 year survival of our diabetic patients. And on the other hand, again, the pedal arch status affected the 1 year survival rate of our patient, with about 80% of survival in patients with incomplete or complete pedal arch, and about 60% of survival at 1 year in patients with absent pedal arch. And we published in the same period another paper in International Angiology, and the title of this second paper is very, very impressive according to me, in my opinion, because pedal arch patency and not direct angiosome revascularization predicts outcome, limb salvage and survival of endovascular interventions in diabetic patients with CLTI. And in these last slides, I would like to share with you the last paper of this like a trilogy, okay? Because I took the patients of the first paper published in 2018 in Korean Journal of Radiology. So 153 diabetic patients with foot wounds underwent peripheral endovascular revascularization, and I followed these patients for 5 years. in order to evaluate the effect of pedal arch quality on 5-year survival and limb salvage in diabetic patients with foot wounds undergoing peripheral endovascular revascularization. And you can see in this slide, very impressive, that the survival at 5 years did not differ between the 3 groups, but the overall outcomes are very, very, very poor. So our patients with the complete pedal arch had a survival at 5 years of about 40%, and the patient with incomplete or absent pedal arch had a survival at 5 years of about 20%. So 1 patient on 5 survived at 5 years after an endovascular revascularization in patients with CLTI and foot wounds, okay? And if we analyze the outcomes in terms of limb salvage, in this case, at 5 years, there is a strong statistically significant difference between the patients with complete or incomplete pedal arch, with a limb salvage rate at 5 years of about 95%, and patients with absent pedal arch, because the limb salvage at 5 years in patients with absent pedal arch is about 75%. And in this study, I performed a multivariate analysis just to analyze the factors affecting the limb salvage at 5 years. And in the whole population study, multivariate analysis showed an association of smoking, chronic renal failure, and severity of foot wounds with survival, and coronary artery disease, severity of foot wounds, and preoperative pedal arch status obviously showed a strong association with limb salvage. And I published the last in 2021 in Vascular Journal this paper with the title Influence of Pedal Arch Quality on 5-year Survival and Limb Salvage in Patients with Diabetic Foot Ulcers Undergoing Peripheral Angiography. So, Mr. Chairman, Dr. Arbi, thanks again for the kind invitation, and I would conclude my lecture with these sentences. In our experience, pedal arch quality had a great positive impact on time to healing, limb salvage, and survival in diabetic patients with CLTI. Angiosome revascularization, in my opinion, is not a predictor of good outcomes in diabetic patients undergoing BTK procedure, and no difference in terms of freedom from minor amputation was found in all subgroups analyzed, and the presence of a complete pedal arch could be considered a predictor of good outcomes in diabetic patients with CLTI, and preoperative pedal arch quality significantly affected limb salvage but not survival at 5 years, and smoking, chronic renal failure, and severity of foot wounds affected the 5-year overall survival, but coronary artery disease and the severity of foot wounds and obviously status of the pedal arch affected the 5-year limb salvage. Thank you very much for your attention.
Thank you very much, Rose. It's really a very impressive topic to discuss. I would like this, Dr. Abdullah, is he around?
ايوه موجود. سامعني محمد؟
ايه اذا عندك سؤال تفضل لانه نفس التخصص ف
Yeah.
It's yours.
Yeah, thank you, Dr. Sherwat, for a very nice presentation. My name is Abdullah Wahbi. I'm a vascular surgeon, and I think I am older than you. So I don't know if I can get the picture or a video. I don't know. Anyway, it's very impressive. The angiosome concept, when it came, it had a lot of excitement along vascular surgeons in their practice. However, my question is, when I followed the angiosome concept, now, for us as a vascular surgeon, is it gonna change our practice? Like what we do, the most important thing when you have a diabetic foot patient is to assess the vascularity. And we always instruct our residents, our family physicians, if you have any lesion and you cannot feel a pulse, not Doppler signal, if you cannot feel a pulse, then please refer him to us, because most likely there is an element of ischemia and he needs revascularization. And then we do the usual, the CT angio, and we try to correct if he has any lesion by endovascular or open. But do we need to go, like in every patient, to assess their arch and the patency of the arch to decide exactly what to do? Because what we're doing is, if we find something in the CT angio, like a lesion in the SFA or the iliacs or anywhere else, we just go ahead and vascularize. Either if you open the tap of the inflow, just opening the tap, even if you find the lesion upward and you cannot do anything, opening the tap can give you some improvement in blood supply and hopefully help you in healing the wound. So will that, when I followed the angiosome concept, I'm just thinking, will it affect our practice? Is there anything different in our practice as a vascular surgeon dealing with diabetic foot infection, or will you just continue to do what we do?
In my opinion, we must discuss about different kind of patients, because if we talk about patients with intermittent claudication with an iliac stenosis, or patients with a stenosis of SFA or isolated stenosis of popliteal artery, we are talking about different patients. As you can see in my studies, I performed an analysis about patients with lesions, with foot wounds. So we are talking about diabetic patients, and usually diabetic patient has a BTK or BTA disease. So I think that in our patients, we cannot finish a peripheral angiography without a double check with the two projections, two X-ray projection of the foot. We must see the foot arteries in our diabetic patients. And if we have a good network, a good multidisciplinary network with colleague diabetologists, etc., usually we know where is the lesion. And so we must invest the first time of our endo procedures in revascularizing the angiosome. But for example, if we have a heel lesion, usually the posterior tibial artery is closed. So I must invest my first time of the endo procedures to revascularize the posterior tibial artery if I have a heel lesion. But you can see that in the literature, and even in my personal experience, the rate of revascularization of angiosome, direct revascularization, is about 60%, because the most diseased artery of the 3 BTK vessels is localized where the lesion is. So it's the hardest target vessel to revascularize. So in my personal opinion, you must invest the first time, the first minutes of your procedures to revascularize the target, the angiosome direct vessel. But if you failed, you can change your mind, you can change your procedure in order to go a direct inline flow to the foot and to guarantee a pedal arch patency in order to revascularize all the collaterals of the foots. For example, if you have, in my personal experience, I had some patients with the heel ulcer. I was not able to revascularize the posterior tibial artery, but I was able to revascularize the anterior tibial artery and to perform a pedal plantar loop in order to give blood, a blush to the heel from the pedis artery and from the plantar artery and from the pedal arch. So in terms of angiosome theory, I did not perform a direct angiosome revascularization, but for the wound healing, I was successful because I revascularized the pedal arch. So we must change our mind about the angiosome theory and about the pedal arch. I think it's more important to have a good pedal arch in our diabetic patients.
Great, I agree with you. But if you find, as you said, I'm just confirming what you said, most of our patients First of all, to get a clear picture by angiogram or whatever for the pedal arch, sometimes it's hard because the inflow of the contrast to go there is hard. And sometimes it's open, but because the contrast is not going, it doesn't give you a good picture. So let's say you find a patient with the angiogram that he has no pedal arch. Will that stop you from doing any kind of revascularization?
No, I perform an effort of revascularization usually, but I know that if I have a preoperative angiography in my patients with absent pedal arch, I know that this kind of patients is a non-success. In any case, in terms of limb salvage and in terms of survival, I showed you that the survival of this patient with the absent pedal arch at 5 years is 20%, and the survival at 1 year is 60%. So when I perform the first angiogram of the foot, and I see with my eyes that there is no pedal arch and no foot arteries, I know that I have a patient with a potential death of about 40% in 1 year. So I can perform an effort to revascularize the pedal artery, okay, but just to improve the time to healing and the possibility to have a wound healing.
Yeah. So anyhow, you will revascularize. That will tell you about the progress of the patient. But anyway, you will revascularize and give the patient. Yeah. Thank you so much it's very informative. Thank you so much for your contribution.
Thank you for the questions.
There is one question from Dr. Richard Pacey. He was our chairman yesterday in the chat box. Would you mind to read it, Dr. Triozzi?
Yes. The question is, did you find an impact of heart failure on survival as found in Japan and Saudi Arabia? No, as I showed before, there is an impact on 5-year survival of coronary artery disease. But it's quite obvious because if we have patients with the coronary artery disease, the coronary artery disease is a negative predictor of survival at 5 years in all patients and above all in diabetic patients with CLTI, but no impact of heart failure or on survival. If Dr. Pacey means heart failure as coronary artery disease, because in my database, I set the term coronary artery disease in terms of coronary artery disease. Heart failure sometimes can mean even a bad function of the ventricular pump, etc. So I mean coronary artery disease as an obstructive disease of the coronary arteries. In these terms, the coronary artery disease had an impact on 5-year survival of diabetic patients with foot wounds. Thank you to you, Faisy.
Any question from the audience? Otherwise, I have one last question. Any question from the audience?
Yes, please, Dr. Muhammad.
Hey, Dr. Ahmed, tafadhal, go ahead.
Assalamu alaikum. Good afternoon. Thanks, Doctor, for this nice presentation. Based on the angiosomal theory and the identification from Dr. Al-Wahbi about it is difficult to assess the pedal arches by conventional CT angiography. For better delineation, is there any recommendations for selective angiography for below ankle vessels?
So you mean to perform an angiography to BTA vessels?
Yes, to enhance the sensitivity of the imaging, to choose for the better treatment. Is there any recommendation even for consideration or in the future for selective angiography for distal arteries, especially below ankle vessels?
Yes, in all the patients. In my personal clinical practice, I did not perform a CT angio in my diabetic patients. I performed with my fingers a duplex scan because in Italy we have not the possibility to have sonographers. So we vascular surgeons perform in our patients. And if I have a good inflow a good iliac inflow, so a good pulse, triphasic flow on the common femoral artery. If I have a good SFA with okay, a stenosis or SFA in the channel, Hunter's channel, etc., but I have a good inflow, I perform directly an angiography to my patients. I did not perform an angio-CT. And when I perform an angiography, I started with the preoperative angiography with the selective angiograms of the SFA, popliteal arteries, BTK level and BTA level, and foot in tube projection, anteroposterior, and with an angle degree of about 25-30 degrees opposite to the foot in all my diabetic patients, before and after the revascularization.
Yes, clear. Thank you.
One last question. Anybody, any question from the audience, please? Okay, Dr. Teresi, do you consider the pedal arch as a predictive value, or at least a risk factor that we can consider its importance in our clinical judgment? You know, sometimes you know that the pedal arch is closed and the mortality rate expectation is high, and then within some time, so we are not going to offer the patient too many surgeries that not required at this time. So do you consider this as a risk factor or as a predictive value for the complexity of the procedure that we may do for the patient, either to the diabetic foot itself or for other organs if needed?
I think that, but I haven't the numbers to demonstrate this, but I think that the pedal arch status is a marker of a systemic disease. So the pedal arch status is not just related to the diabetes or to the critical limb ischemia, but pedal arch status is related to a systemic disease. So I think that there is a correlation between the pedal arch status and the cerebrovascular disease or the coronary artery disease. Because my data support the fact that the pedal arch, the absence of pedal arch means more limb loss and more death in our diabetic patients. So I think it's a predictor is a marker, not a predictor, a marker of systemic disease. It's another kind of disease rather than a stenosis of iliacs or a stenosis of SFA. It's a different disease. The absence of pedal arch and the BTA disease is a different disease. Another key point is the grade of calcifications. I did not talk about the grade of calcification in my lecture, but we have a new classification from my friend, the interventional cardiologist Roberto Ferraresi, about the BAC and MAC, so the MAC and SAD, small artery disease and big artery disease, and another classification about the grade of calcifications of foot arteries. And so it's very important to see the grade of calcifications, and the grade of calcifications has an important impact on the difficulties to revascularize the BTA vessels, obviously, as happens even in other districts such as femoropopliteal arteries.
Well, I think we are done. Any question from the audience? Thank you very much, Dr. Horzi. It is really a pleasure, and I'm sure that we will be in touch soon. Your lecture is very impressive, very important to be addressed for clinical practice. Thank you very much.
Thank you to you again for the kind invitation, a good initiative.
Thank you very much. Thank you. Ciao, ciao.
Ciao.
I think we are done for today, my friends. As I told you, we have 3 or 4 lectures for today. One of them has been done yesterday already, and the second one postponed up to 26. And we did 2 lectures already by Dr. Sonal and Dr. Nicola. This is our last lecture, so we'll meet tomorrow, inshallah, on just give me 1 minute. We'll meet tomorrow on 2 p.m. We have a lecture by Dr. Honda Su from China, long-term follow-up for microsurgically reconstructed diabetic foot. And Dr. Raja from India will speak about healing ulcer and preventive of their recurrence in the diabetic foot. And Dr. Thomas Serena from USA, also he will talk, and Dr. UK from Switzerland. So we have 4 lectures tomorrow. Hopefully we'll finish early. Thank you very much for your attendance, and we will meet tomorrow. Thank you very much.